Welcome to the channel of Problem Solving in Clinical Dentistry. Today we are going to discuss the key principles for predictable anterior implant success. This session is divided into two parts, Section 1 and Section 2. In Section 1, we discuss the clinical steps. In Section 2, we discuss the evidence from scientific literature. So do watch this video till the end to get the complete knowledge for predictable anterior implant success. And if you like this video, please subscribe, give your comment and likes. So this is my educational and clinical disclaimer. This is mainly for academic and scientific discussion. There is no conflict of interest. Now, what are the key learning objectives? It is to know the key intraoral and extraoral examination that we have to do, to know the key radiological features which guide us in placing the implant in aesthetic region, and to apply them clinically to get optimal aesthetic in the long term in anterior region. So session overview. In section 1, we discuss the step-by-step clinical protocol, and in section 2, we discuss evidence from literature. So step 1, the most important step when we have to extract a retained root is to do an atraumatic extraction. We want to preserve both the hard tissue and soft tissue to get a good aesthetic. So this is the most important step, and we have to see that we do an atraumatic extraction. So in step 2, we can see here in the clinical picture that the labial cortical plate is well preserved, and the importance of labial cortical plate is well documented. And when we do an atraumatic extraction, we have to ensure minimum damage to labial cortical plate. In step 3, immediate placement of implant is done to preserve the hard tissue architecture as well as to preserve soft tissue. This will ensure that minimum ridge alteration occurs during the healing phase. In step 4, we place a bone graft both in the jumping gap as well as labial to the implant in the soft tissue area. This dual grafting technique helps us to give a good aesthetic outcome in the end. Immediately post-implant, intraoral periapical X-ray helps us to determine the correct placement of the implant in relation to the adjacent tooth. We also did an immediate post-implant CBCT to ensure that the labial cortical plate is well preserved, as well as in 3-dimensional the implant is well placed. In step 5, we place the healing abutment to ensure the good soft tissue healing as well as to get a good emergence profile. This healing abutment helps to modify the architecture as well as to give a good soft tissue stability, and it is very important for anterior implant region. Now post healing, we can see that we have got a good pink aesthetic. The soft tissue is well formed, and we can see both the height and width of the soft tissue stability is well preserved, and it is ready to receive a good prosthesis. This is the palatal view, where we can see that this soft tissue is well formed. In step 7, we place the impression coping over the implant to take a closed mouth impression. In this case, as it is a single implant, we don't go for an open tray technique. A transfer cap is placed over the impression coping so that this transfer cap is transferred to the impression tray, and it will help in ease of alignment of impression coping in the impression which we record, so that there will be less misalignment of impression coping and the implant analog which we will place during the cast fabrication. In step 8 is a very important step. Why? Because here we do the correct selection of the abutment, both in terms of the gingival height of the abutment as well as for the implant height and width. Now in anterior aesthetic region, correct selection of gingival height of the abutment is very important, because if we don't do correct selection, then we will not get a good emergence profile. If the gingival height of the abutment is less, then there will be a chance that the prosthesis will be submerged. If the gingival height is more, then there will be a chance that the emergence profile as well as the prosthesis will be exposed, and it will not look good in anterior aesthetic zone. So this is the most important step, and most of the time the clinician fails to get a good abutment selected according to the patient's gingival height as well as the angulation of the abutment, which we will see later. Now we have seen in the previous slide that the angulation of this implant is not correct. It is very much labially placed, and this labial angulation of the implant is to be corrected by placing an angulated abutment. This angulated abutment will correct the labial inclination, and it will help to give a good prosthesis in the anterior aesthetic zone. Now in step 10, we do a jig trial. This step is also very important, because in jig trial, we ensure that the cast which we have prepared and the abutment which we are using is in a correct position as it is in the patient mouth, so that when we will place the final prosthesis, there will be less problem. So we have to ensure that jig trial is done properly to avoid future problem during the final prosthesis insertion. Now this is another important step, that step 11, that abutment placement with screw channel. The screw channel is properly oriented. If the screw channel is not properly oriented, there will be problem during the screw tightening of the abutment. There will be problem during the crown insertion. So this is another important step, that when we place the abutment, we have to ensure that the screw channel is properly oriented. In step 12, this is another important step, that we ensure that the recommended torque is inserted into the abutment screw, so that the implant and abutment are in a proper stable position. If we apply too less torque, then there is a chance of screw loosening. If we apply more torque, then there will be a chance for that abutment screw fracture, and that will cause another problem, and that problem will be of a very serious nature. So recommended torque, where we can see in this picture that 20 torque has been applied in the abutment screw for tightening of the abutment with the underlying implant. So this is the final processes. The process is placed in the patient's mouth. We can see that it is well formed, and it will satisfy the patient both aesthetically as well as functionally. So this picture shows the implant with restoration in centric occlusion. 1 year radiographic follow-up, periapical X-ray. Here we can see that implant is in good functional position. There is minimum loss of bone and the implant is functioning well. This is the pre and post smile photograph. We can see that the patient is restored properly and the patient is having a good smile. In section 2, we will discuss the evidence from literature which guide us in taking these clinical steps. So when we place implant in anterior aesthetic zone, there are certain challenges, and that challenges can be met only by doing a good intraoral and extraoral examination. So first we will discuss the soft tissue assessment that has to be done. So in soft tissue assessment, we will assess the smile line, we will assess the gingival biotype, we will discuss the importance of gingival biotype, we will discuss the gingival margin level of the soft tissue relative to the adjacent tooth. We will discuss soft tissue thickness for masking the abutment color. So this is another important thing, that what should be the adequate thickness of the soft tissue so that the titanium, which is of a blackish color, is not visible underneath the gingiva. So these are the important things. So first, the smile line. In this literature, Khan and his colleagues studied the smile line of South Indian population. Now, many of the studies are mainly for the Western population. In this study, this was done for the South Asian population, where he described the importance of smile line in satisfying the aesthetic outcome of the anterior region. Here we can see the smile line is not high. That means the gingiva is not much visible. So this is a favorable condition for placing immediate implant in aesthetic region. If the smile line is high, there is a high chance that if there is a ridge alteration after tooth extraction, there will be certain changes which not be very much favorable for aesthetic outcome. Next important step to ensure is to have a correct assessment of gingival biotype. If the biotype is thin, then it is seen in the literature that there is more chance of gingival recession. Now, how do we assess whether a gingiva is thin or thick? Now, one simple procedure is that if we place a probe and that probe is not visible underneath the gingiva, we consider the gingival biotype as a thick biotype. And if the probe is visible underneath the gingiva, then we may consider that it is a thin gingival biotype. So if the gingival biotype is thin, Again, placing an immediate implant after tooth extraction, it may cause problem in long run, mainly with respect to the aesthetic of the patient. So what to do if the gingiva is thin? It is better to go for a soft tissue graft to increase the thickness of the gingiva and then place the implant to minimize the risk in the aesthetic outcome of the implant restoration. Next, we have to see that what is the level of the gingiva in relation to the adjacent tooth when we place implant in the anterior aesthetic region. Now, either it may be in the same level of the adjacent tooth. If it is not in the same level of the adjacent tooth, what are the steps that we can take? Now, one simple step is that we can go for an orthodontic extrusion of the fractured tooth. If we go for an orthodontic extrusion, the gingival level is brought down and it will help to have a good aesthetic result. Because if the gingival level of the region where the implant is to be placed is of not in the same level with the adjacent tooth, there will be high chance that in the long run it will cause gingival recession. Now here the most important thing, that what should be the adequate thickness of the soft tissue so that the underlying titanium abutment, which is grayish black color, is not visible underneath the gingiva. Now Young and his colleagues did a landmark study and they found that if the gingival thickness is 2 mm or less, it is better to place a zirconia abutment rather than a titanium abutment to avoid the black display of the underneath grayish and black titanium abutment and implant, rather than we have to give a zirconia abutment. Now, hard tissue assessment. When we place an immediate implant in anterior region, there are certain hard tissue assessment which are very important. So number one is there should be at least 2 to 3 millimeter of sound bone apical to the root apex of the tooth where the implant is to be placed to get the primary stability. We have to assess that what is the sagittal root position and what is the shape of the fractured labial cortical plate, whether it is V-shaped, whether it is U-shaped, or whether it is inverted V-shaped. Now here we can see that we have got a sound 2 to 3 millimeter bone apical to the root apex, and this helps us to achieve a primary stability when we place implant immediately after tooth extraction. Now next thing is that what is the angulation of the tooth in the sagittal plane. Here we can see that the tooth is kissing the labial cortical plate. Now by God's grace, in 80 to 81% of the cases, the labial cortical plate is touched by the root of the tooth. So this is a favorable condition so that if the implant is placed, we can have at least some amount of freedom to place it more palatally. Had the tooth is more palatally placed, then this freedom of placement of the implant palatally would have been lost. So we have to assess that whether the implant is to be placed more palatally, whether there is a scope, and whether the tooth is labially placed or it is palatally placed or it is in the middle. So this Khan and colleague had done this remarkable study. So what if the next thing is that, what is the labial cortical plate if it is lost and fractured? Does the shape of the labial cortical plate, if it is V-shaped, inverted V-shaped or U-shaped, has any role in the clinical outcome? Let's see. So Joseph Kahn and his colleague did this remarkable study, and they found that if the defect in the labial cortical plate is V-shaped, the clinical outcome is little favorable. If it is inverted V-shaped, it is still favorable, but if it is U-shaped defect in the labial cortical plate, the clinical outcome is less favorable, because more amount of alveolar bone proper and more amount of bundle bone loss is there, and it has got its clinical significance. So what are the clinical decision making points? So if the smile line is very high, don't place immediate implant. Wait for ridge alteration, and we can go for delayed implant placement. If the patient is very aesthetically demanding, immediate implant placement should be done with a caution. We should consider staged implant placement. If there is a thin gingival biotype, again, immediate implant placement should not be done. Rather, soft tissue augmentation should be done, and then implant should be placed. If there is no bone apical to the root apex, then delayed implant placement or some bone grafting has to be done. And once the healing takes place, then only we have to place the implant. If the defect is U-shaped in the labial cortical plate, again, immediate implant placement will not give a favorable result. We have go to for a GBR or delayed implant placement. So the most important thing is now that is single implant restoration in anterior aesthetic zone is a complex procedure. Durham and his colleague answered this question that yes, this is a complex procedure, and when we take such type of cases with the hard tissue and soft tissue examination, we should do with caution, and we should have a good scientific backing in doing this procedure. So these are my key clinical references. I thank you for your patient hearing. Thank you.